We've heard a lot about inflation and what it impacts and what other silos in the economy does it impact. But we really haven't heard a lot about medical inflation nor medical plan inflation. And there are differences. And what is the impact relative to the overall economy to what we see going on there? And it kind of struck me that this sits kind of on the sidelines and we hadn't really talked about it much, but it makes up a major portion of the amount of dollars that we spend each and every month taking care of ourselves. Joining us to talk about is the managing partner with PCS Advisors, Paul Seegert. Paul, welcome to the show.
Thank you for having me.
Paul, is that a fair way to characterize this? I mean, we've kind of not really discussed this. It's kind of been sitting there on the sidelines, and you know, I read a lot, and I just don't see a lot being reported on this.
Yeah, I think that is fair. It's something that we never seem to solve as a country. And so, and even when attempts are made, I think a lot of times they result in a good press event for folks, but they don't make a big impact and bend the curve at all. And employers end up carrying the load in our healthcare system as it sits today. To me, when I step back and look at what's going on, one of the most alarming trends that we have is the fact that 20 years ago, 2 out of 3 of us got our healthcare at work. Now we've crossed a critical number in the last, coming out of this COVID experience, 49% of us now get our healthcare at work. And that matters quite a bit because the whole healthcare system relies on these commercial payers to make their profit margin. Hospitals and other provider groups may even lose money. Many times they do lose money on a transaction when someone shows up with Medicare or Medicaid, and that was sustainable when they knew they would have commercial payers coming that they could charge much more, and that's a dwindling pool. So it's not a good setup for employers as we head into the next cycle of renewals and so on.
Where does the folks that exercise the plans under the Affordable Care Act, where do they fall out in that equation?
Yeah, that's an interesting part of this whole conversation. We keep seeing short-term subsidies infused into that program to insulate consumers from how well it's working or not working financially. This cycle that we're in right now, this renewal season, those plans, we looked across more than 70 markets where those plans are offered, and the average increase in cost was 10%, so not small. But with the Inflation Reduction Act, they have put many, many more billions of dollars into that program with additional subsidies through 2025. So those consumers that are consuming those products won't feel that, but it is still, costs are still going up. It's still a big expense within the system.
How much longer can we continue to go down that path where we are increasing and are involving ourselves in these subsidies moving forward? Because the more I would got to imagine that the more you do that, the more that plan becomes luring to others if the pain keeps getting pushed down the road, right?
Yeah, we've created this situation. I keep thinking we're at the inflection point or the breaking point, and then more money gets thrown at the problem, and it doesn't seem to get solved. But you've got a situation right now where more and more small employers who used to take pride in offering health care to their employees and used that as a way to attract good employees and keep good employees and so on are getting priced out of it. And they're looking at it and saying, shoot, am I even really doing my employee a favor with the level of coverage that I'm able to continue to afford to buy for them or cost share for them? They're in this high deductible plan. And when they go to use the plan, they end up in debt. Shoot, if I just stop doing this and give them a little pay raise and tell them to go to the exchange, they'd be better off. And I can see where some small employers might make that decision, and at their level that very well could make sense for them and for their employees. But it's a scary trend for our overall system.
How much of this is motivated by the mindset of the younger worker today that's really more interested in what that take-home pay number is every Friday as opposed to whether or not you're contributing to a 401k, health care, pension, or otherwise?
It's definitely part of it. Affordability is an issue, and I think you make a good point there that lots of employees don't realize how much their employer actually spends on healthcare. Starbucks spends more on healthcare than Beans. GM spends more on healthcare than car parts. I mean, it's become like this ridiculous expense for employers. For lots of employers, it's their second largest expense, and they're not. And yet, as an employee of a company, what you're watching at your level is that the amount of coverage you get seems to go down each year, and the amount of payroll deduction seems to go up each year. And we've put another part of this whole equation that we don't talk enough about, I think, is that this Affordable Care Act era of health care has resulted in, depending who you believe, I tend to believe credit reporting bureaus, as many as 100 million Americans in medical debt. Well, we only have about 30 million at any given time that are uninsured. So most of them have insurance, and I would suspect it's even more than 70 out of that 100. So we've put a lot of people into a situation where they're functionally uninsured. Their employer's spending more than they've ever spent to get less appreciation than they've ever had as a result. The employees have no idea that it's become such a large expense in many cases. And we're at a place right now, 53% of our hospitals are going to post an operating loss this year. And when you say the word subsidy, everybody thinks I'm about to start talking about the government. And I do talk about the government subsidizing these programs. But I think almost nobody's talking about the fact, and we need to, that government payers, Medicare, Medicaid, and even these exchange-based plans, they don't cover the cost of care for the people they're covering. And so that puts the whole system, really the government is turning to these employers and saying, we want you to make the system work. if whenever somebody comes to me and says, well, shoot, we should just have single payer, it'd be a lot cheaper. Not at the quality that we all enjoy.
Well, it's been like that for decades, right? This hidden employer related tax number out there where commercial pay covers for government sponsored plans, Medicare, Medicaid. I sat on the hospital board here locally in my jurisdiction for over 20 years. And your mix, we used to call it our Medicare, Medicaid mix. We spent as much attention on that as we did as anything else. And as it grew from 52% to 62% to 72 or 74%, what we saw is that we had less and less money. We're very difficult to keep up with technology because we just didn't have enough commercial payers to overcome the burden of Medicare and Medicaid and uncompensated care, which are just people walking into the ER every day with insurance, and you have no ability to move these folks anywhere. You take it on the chin, you pay for all of that care, and hope, and I say that loosely, that government will reimburse you at some point in time. Right.
And for that reason, you see more and more rural facilities close because their customer base is now almost exclusively that Medicare, Medicaid mix and uninsured. And then you have folks trot out and say, well, shoot, this is a problem. We need to solve it. Well, and then reimburse appropriately.
So when we come back after the break, I want to talk more about where we're going to go from here, where you think. And there's a phenomenon going on here. And when I read this in a McKinsey report, and I think you referred to this in one of your most recent articles, that consumer prices have rarely risen faster than healthcare inflation. It's always been inverted. Healthcare inflation was always much higher than consumer price increases. But that's not the case today, and that's kind of a weird phenomenon, and I'd like to dig into why that is and why we're experiencing that at the present time. We're visiting with Paul Seegert, Managing Partner, PCS Advisors. We will talking about medical inflation, folks. We will be right back. Stay with us. Welcome back, folks. We're visiting with Paul Seegert, Managing Partner, PCS Advisors. We're talking about rising medical costs combined with a whole bunch of different things that are coming down the pike that we're about to talk about, and one being COVID-19 government subsidies. And when that goes away and moves to commercial carriers, what will happen? So, Paul, let's talk about this phenomenon where consumer prices are rising faster than healthcare inflation.
Yeah, what you have with healthcare is a pretty strong delay in inflation showing up in the way that most of us pay for it with insurance because of multi-year agreements between insurance plans or large health plans and then hospitals and providers. A lot of times those will last a couple of years, and many of them were negotiated before a lot of this inflation hit the system. So they have seen costs rise. 53%, as I mentioned a minute ago, lots of hospitals, a majority, will post a loss this year. A lot of that having to do with the cost of labor going up, a shortage of nursing staff that's predated the pandemic and only gotten worse, and other kind of more run-of-the-mill inflationary forces for all of their goods that they need to run their facilities. That's all been happening, and yet, for the most part, these facilities have been locked in to set reimbursement rates and having to wait until these agreements come up for renegotiation. So that will all happen as we go through these coming months and show up in the next enrollment cycle. So while lots of employers were surprised that they got an increase, but it wasn't as bad as they thought it might be, the unfortunate reality is that it's coming. It's just coming with a delay. At the next
so
cycle.
we can anticipate 2023, 2024 of that dam breaking, and medical inflation ends up being, you're looking into your crystal ball where?
Mm-hmm. Yeah, I think double digits for sure. Yeah, because as you pointed out, historically, healthcare inflation has run higher than the rest of the market, 2 to 2.5x, which is a scary thing to say right now. And I don't believe.
So, for the benefit of the listening audience, that means if that inflation is running at 8, medical inflation is running somewhere between 16 to 20, right?
Right, exactly. And so I think we'll see 12, 15. I think it's fair.
So when we think about this, and we move from just general medical inflation and we focus in on medical plans, there is a different inflation factor for that, right? A medical plan inflation rate.
Mm-hmm. Yeah, and there's.
If you would, for the audience, describe the difference, because that's what they really feel, right? Even more so than medical inflation. If they're part of a plan, they're really feeling that medical plan inflation rate.
That's right, and that's an even higher number, generally speaking. It's going to take in medical inflation, and then on top of that, they're going to cover their cost of running the plan and their profit margin, and some of which is certainly justified, and some of it we could maybe say is waste. Certainly you could say is waste. So it hasn't been uncommon for medical inflation to be 5, 6, 7%, and an employer's health plan to go up 10%. And so it'll be a little more dramatic than what we're talking about in terms of healthcare inflation for the health plans. And I think we have lots of employers out there that are, depending on size, the bigger employers maybe can weather the storm a little better than small employers, but a lot of that ends up getting passed on to employees. Even pre-COVID, increases in payroll deductions were outpacing increases in wages, and I think that trend continues and maybe gets a little more aggressive.
So are we hitting what is referred to sometimes as a perfect storm relative to really almost a medical disaster here? So many different articles on high attrition rates in medicine, shortages of nurses, allied health professionals, doctors. Then, you talk about these medical plans. I mean, typically the mindset, I know the term of art used to be population management, right? Took a lot of technology and a lot of human capital in order to do so. But with all of these shortages, and if better than 50% of hospitals are going to be posting losses in the coming year, not as much disposable income for capital investment in technology and the like, it seems to me we're headed to just a disaster confluence of factors that are going to just be mind-boggling.
Oh, we are. We're headed into a shortage of. I mean, the nursing shortage is extreme and has been extreme, and the causes of it. It's a circular problem where when you ask nurses why they're leaving, they tell you it's burnout, and the lack of nurses creates more burnout, and then
right.
you throw the pandemic and everything else. So that one is a tough one to solve, and there's lead time, and you've got all these kids in the education system that need to come out and so on. We're doing the same with providers. We're doing especially the primary care level of doctors. That's been on the decline. In our system, it's very, very difficult anymore to be an independent practitioner and a primary care provider. They end up getting gobbled up by large health systems and having to see 80 or 100 patients in a day to make it work, and that's changed a lot. And I think we're paying a pretty serious price for that in just the overall health of the population. We need primary care, and that's been on the decline. So yeah, I think perfect storm is an accurate description. What we really need, I know I depress people a lot on these interviews, but I'm actually very optimistic too. Employers many of them who have gotten to that breaking point are figuring out how to run and manage their health plans better by taking a lot of the same things that they've used in other parts of their business and bringing it into the healthcare part of their business. They just can't ignore it anymore. So they're getting transparency. They're bringing in free market forces, which is what we need to fix this. You already see the fix out there. If you look at healthcare procedures where the insurance payment model is not involved. Look at LASIK. Look at getting a dental implants put in your mouth, or look at cosmetic procedures. Quality goes up, cost goes down year over year. But you have transparency, and you have people that are competing in a free market way. And our healthcare system, with this insurance payment model and the lack of transparency, historically has not worked that way, and that's just not going to work in the long run.
Do you find that most employees have no clue what their employer is actually offering and how much and the extent of their subsidizing the plan?
Very much so. And I think employers have not done a great job, probably because you just kind of do what you've been doing. And many years ago, it was a fringe benefit that had some cost, but it was pretty far down on your cost stack. Now here it is number 2 maybe for you as an employer, and employers haven't done a great job of quantifying that for the employees, and they only find out when they leave and go on COBRA. By then it's too late. So some employers are realizing that and communicating that each year in a kind of total compensation statement format to employees to say, look, you're getting X dollars in wages, and we're also spending this much in your retirement program and your health care and your so on. And it's very eye-opening for lots of employees to see what their total compensation is, were they to go out and buy these things for themselves in the open market.
Let me pivot back real quick for the benefit of the listening audience. When we increase participation in the Affordable Care Act, what kind of disruption does that actually cause, as we just described this economic principle of how commercial insurers are covering the shortages of government-sponsored plans?
Well, we're adding to the number of people who, when they show up, are under reimbursing the facilities, which means those facilities have to turn around to commercial payers and say, hey, we're going to have to charge you even more. So they're just squeezing the balloon and pushing cost over to these commercial payers, these employer payers. It's this dwindling supply of payers. So we are working really hard right now on creating these free market plans and transparent plans for employers in expectation that this coming couple of years has the potential to be pretty catastrophic for employers if they don't do something about it. You've got the inflation that we talked about heading toward their plans. And then you also have the fact that the providers are going to have to come to the negotiating table very aggressively because the commercial payers are in dwindling supply, and they make the whole system work.
But have we not set them up to fail? I mean, because when you think about the rhetoric coming out of D.C. today, you're not a good corporate partner if you raise premiums. Corporations are bad people. All they do are taking advantage of their employees. And every time, Congress offers a subsidy or increase a subsidy for ACA so that their participants don't feel the brunt of medical inflation like everybody is on the commercial side, and you're bad if you vote against that, right? And it passes. It seems to me like we're really setting this up to fail, and it wouldn't surprise me if you and I are having this conversation 4 years from today, and instead of 49% being employer-sponsored healthcare plans, we may be in the 30s.
I agree. And that's only then, I think, will we as a population start to realize that while it sounds nice that nobody pays for healthcare and you have a single-payer system and all of that, only 10% of us have a passport in this country. We don't really know how that looks in other countries and how it works. You have 60, 70,000 Canadians a year that can afford it that come here for surgery because they don't want to wait for months and months and months and months and months. And you have wait lists that are much longer. You have people that need to get treated for cancer that have to wait months before they can start, and so it gets worse. These are not anecdotal stories. The data supports this. So we
which
do
is
have
not
the best
which is not what we're accustomed to, right?
Not at all. No, you can ration by price or line. We're not line people.
Right. I mean, we're accustomed to, if we have a diagnosis of cancer, that we're looking to get into a doctor within 2 weeks. We're not waiting 6 months. I mean, that's not what we're accustomed to here, right? And I think a lot of folks don't recognize that that's where we're headed. I have several friends up in Canada. There's, they talk about their health plan. Some of it works well. But other provisions of it, if you don't have money there where you can exercise other options, you'll be waiting 6 months in order to get a surgery done relative to a cancer diagnosis.
Oh, yeah. It's 11 weeks to get an MRI there. And they have about 2% of their population at any given time is waiting for a surgery. I mean, and if we, maybe at that point, we'll wake up here and realize, hey, and hopefully we can solve it before then. I mean, we're working hard on a daily basis to work with employers to do that. I think they are the solution for now, because there just isn't any political will to fix it, unfortunately.
Well, it's kind of like in the Inflation Reduction Act. I keep hearing how, we passed this bill. We're going to be able to negotiate prescription drugs. Well, the truth is they're going to negotiate 10. And I think the first year that they're going to negotiate, correct me if I'm wrong, if you don't know, just tell me, it's either in 2024 or 2026 is the first year that they can do that or something. Is that right? Yeah, it is. And when they do, again, we're going to see, it fits into our overall conversation of a balloon getting squeezed. Nowhere does it say they can't charge other payers more. So what are we going to do to commercial payers for those same things? It's just going to drive. Well, but I mean, and yeah, that's one of my points. That is the model, right?
Yeah,
and,
yeah.
I mean,
yeah, well, exactly right. Yeah.
And it's almost like we've decided that employer-sponsored commercial insurance plans are now, we've planned their obsolescence in many respects. And it's going to be interesting to see where this goes. When we come back, final thoughts. Paul Seegert, Managing Partner, PCS Advisors. We'll be right back, folks. Stay with us. Welcome back, folks. We're talking to Paul Seegert, Managing Partner, PCS Advisors. Paul, in one of your most recent articles, you point out that a lot of noise and clatter about prescription drug costs, and you make the observation that's only 12% of the total expenditure costs for health care. And that hospitals and physician practices are actually 51% of healthcare expenditures. But that's where people really come in contact with the system more than anywhere, right? Through their pharmacy benefit. What do we see going on there? I mean, I just made the observation about the Inflation Reduction Act and how I think we oversell what's actually going to happen, and we're not even sure what the impact is going to be. But why are we not more focused on protecting U.S. consumers when you can go across the border to Canada and get the same drug for about a third of the cost?
Well, that's a question I get a lot, and my honest answer, although it sounds like I'm being kind of tongue-in-cheek about it, is that as soon as lobbying is no longer effective, we'll fix the drug problem here because we just allow so much waste, and it's so unnecessary. That's one of the easiest fixes for us is in what we do daily in these commercial payer plans is clean up the waste that's attached to the cost of drugs, because it is ridiculous at this point. And most Americans really have no idea that the players exist in the middle of that process that adds so much waste. But insulin's a common conversation in this country as to why is it so expensive here compared to other places. And the answer is because we allow middle players to represent more than half the cost, even though they don't make the drug, they don't wholesale the drug, and they don't retail the drug. And we've got to solve that. We get that kind of waste out of the system, which we do one plan at a time, which isn't the most efficient way, of course. If we could get some common sense transparency rules and regulation around that could be helpful, and really just open it up for free market forces to operate there.
How did we get caught up in this? And I'm assuming you're referring to PBMs, pharmacy benefit managers. Yep. How did the industry end up going in that direction? And I guess there are how many? 5 or 7? PBMs?
There's 3 that run about 80% of the market. There's about 300 that are in existence. And we end up, in most cases, getting employers to transition away from one of those 3 that are running so much of the market because they are adding so much waste. And a lot of this happened in the last 12 years. And then if you go back 12 years, what happened? Well, we rolled out the Affordable Care Act. So we created a situation where the system pushed cost over toward drugs as a way to be able to comply with some of the rules that came about that were intended to control cost, but still continue to grow and increase their revenue. So a lot of this is an unintended consequence of the Affordable Care Act in terms of the amount of waste that's being attached to the cost of drugs. It's ballooned in the last 12 years.
Now, I read an article the other day that the PBM can actually make more money on a drug whose patent has expired than on the distribution of a patented drug. Is that true?
It can be. Yeah, it can be.
And I mean,
well,
huge
they have
amount.
the power to
They were
control.
talking about huge amounts of money. Not
Oh, yeah.
small amounts of money. I mean, it's almost as though
Yeah.
they have a party every time one of their drugs falls off. Their patent runs out.
Yeah, they can. They can. The crazy part of this whole deal is that we allow PBMs to be in control of whether or not consumers can access drugs. That's a lot of power. That's even more powerful than a patent, maybe.
Well,
If I get to say, hey, if you want to be on the drug list that people can use their insurance to buy, then you have to pay me a certain amount. That's really, in simple terms, how it operates today.
Well, why don't we, from an antitrust perspective, why are we not focused more on PBMs than on the consolidation in the market? Because the reality is that as all of these rural hospitals fall out, as you mentioned earlier, they get consumed by other market players, right? Because there's no doubt there's a need in those rural areas for health care. But it's almost as though we're punishing the provider, and we've got this middleman who is just reaping the benefit of every little nuance within our system and really sticking it to the consumer.
We do, without question, and they give with precision. That's why it isn't changing. They just give with precision politically.
Well, they have all the data, right? I mean,
Yeah.
when you control 80% of the market, you're in a much better way to manipulate the system based on empirical data than anybody else.
That's it.
I've never been able to figure that one out, and I guess I never will. I don't know. Paul Seegert, thank you so much for joining us. We truly appreciate your time and obviously your expertise in this matter. I know our listening audience does as well. Thank you so much.
Thanks for having me. Have a great day.
All right, that's Paul Seegert, Managing Partner, PCS Advisors, folks.